Hello, everyone, and welcome to Think New York, a webinar series brought to you by the Empire Center. My name is Kyle Davis, and I am the Director of Public Affairs at the Empire Center, and we are thrilled for you to join our third installment of this informative series designed to provide both decision makers and the general public with essential insights into issues shaping New York State. Today, we have Bill Hammond sharing his expertise on health policy with a specific focus on Medicaid. We'll be delving into the complexities of this program, exploring its impact on New York and the broader healthcare landscape. If you have any questions during today's presentation, please put them in the chat and we will do our best to get to them at the end. Now, without further ado, let me introduce Bill. Bill is an esteemed figure in New York's political and policy landscape and has a wealth of experience and expertise. As Senior Fellow for Health Policy at the Empire Center, Bill brings a unique perspective to our discussions. Prior to joining the Empire Center, he served as a columnist and editorial board member at the New York Daily News. Throughout his career, Bill has been a vocal advocate for transparent and effective governance with a keen focus on healthcare policy. His insights have been instrumental in shaping the public discourse in New York. So, Bill, I'm going to ask you to turn your screen on, and I'll turn it over to you. Thank you so much for being here today with everyone, Bill.
Good morning, and thank you, Kyle. So Medicaid is the most important program in state government, I would argue, because it's literally a matter of life and death for millions of people, including some of the most vulnerable citizens of our state. It's also one of the biggest parts of the state budget. It's been growing at a pretty torrid rate in recent years. And as a result, it's one of the big drivers of the budget debate that's going on right now. So I thought it'd be useful to step back, look at, the big picture of the program, how it's supposed to work, what the recent trends have been, and then zero in on a couple of the topics that are on the table in Albany right now. We're just waiting a second here. Here we go. So to get very basic, Medicaid was born in 1965 as part of the Social Security Act that was passed that year. At the time, the discussion was all about another part of that same bill, which was Medicare, the health plan for the elderly. Medicaid was added as almost an afterthought and didn't get much attention or debate. I don't think people realized at the time what a big deal it was. As of today, it's more or less on the same scale as Medicare in terms of its costs. It covers tens of millions of people, and it costs close to $1 trillion, including state and federal funds. Originally, it was meant to be a safety net for the poor and disabled. It was replacing a lot of charity care that was provided by religious organizations and other voluntary efforts. Plus, it was supplementing a lot of what states and local governments were doing for the poor and disabled. It was always a collaborative program. It was always going to be the federal government would set broad parameters, and then states would have pretty wide discretion within those parameters about who was covered and what was covered and how much was paid. The funding was also a mix with the federal government matching spending by states. The minimum match is 1-to-1, a 50-50 split, and that's the kind of the nominal rate of match in New York State. Other states have a more generous match based on the idea that they have less ability to pay. New York is considered to be a wealthy state because of a lot of wealthy residents. The basic eligibility for Medicaid has to do with wealth. It used to vary quite a lot from one state to the next, with New York being kind of having broad eligibility and other states having much narrower. With the passage of the Affordable Care Act and the Medicaid expansion, the federal government tried to standardize that. Most states have adopted those standards, in which the basic cutoff for Medicaid is 138% of the poverty level. That's about $21,000 for an individual or $43,000 for a family of four. So there there are some subcategories of Medicaid enrollment where they have different eligibility standards, but that's kind of the basic cutoff. Like regular insurance, Medicaid pays for your doctor visits, your hospital visits, your clinical tests, your pharmaceutical prescriptions. Unlike most insurance, it also covers long-term care. So people who are permanently disabled or ill, people who are elderly and unable to take care of themselves, it's kind of the only game in town, other than paying out of pocket, which can be very expensive and difficult. Most people don't have that kind of money. Medicaid becomes the insurer of last resort. So those are the very basics. I think we need to get to understand some of the debate and all, but you need to know a few more things. First of all, it's an entitlement versus it's most budget items are discretionary. Whatever number the state puts into the budget is kind of a limit on what that program is going to spend. But Medicaid is driven by people have a legal right to certain care. The people who provide the care have a legal statutory right to be reimbursed at a certain level for that care. And so the actual spending is driven by the individual decisions of millions of patients and providers. And so when the state writes its budget, what it's really doing is estimating how much it's going to have to spend. And sometimes it gets those estimates wrong. This year is an example of that, where the state was banking on a 13% increase in Medicaid spending, which was one of the highest levels I've ever seen. And instead, it actually got a 15% increase. It went $1.5 billion over. And that's because of unanticipated development, some of them within the state's control and some of them not within the state's control. And so controlling Medicaid costs isn't just a matter of writing a different number in the budget. You have to go into the rules and the laws that govern the program, that determine who's entitled to what. You have to tinker with those laws, and that can be very difficult, and also the result can be unpredictable. I don't think when they created this program and the system of matching funds, I don't believe they anticipated what they were doing, because they created a very powerful incentive for states who are so inclined to spend as much as possible on Medicaid, because for every dollar that they spend, the healthcare system and the economy get $2, including, a dollar from Albany and a dollar from Washington. And the money from Washington is unlimited. There's no matter how much the states spend, the federal government matches it. And this has created a dynamic, especially in New York, of trying to maximize Medicaid spending and also trying to redefine as many programs as possible as medical care and therefore eligible for the federal matching funds. New York, unlike most other states, requires local governments to pay a substantial amount of Medicaid. So that's referring to New York City and the 57 counties. Right now, they're paying about $8.5 billion combined. That's mostly from New York City, $5 billion from New York City, and the other $3 billion is split up among the states. Originally, that counties paid a much larger share. It was, in terms of percentages, it was basically the states and counties split the local share. So, I'm sorry, it was 25% local, 25% state, and 50% federal in rough terms. That was recognized to be irrational and unfair. If you were a small, impoverished upstate county, you would have very high expenses and not a good way to pay those expenses out of your local resources. So, under the Pataki administration, the growth of the local share was capped. And then in the early part of the Cuomo administration, it was frozen at the level it was at in 2015. It's been basically flat since then. Every now and then a governor will come in and kind of renege on the deal and grab more money from the counties, but it's been more or less flat since 2015. The Medicaid, like regular insurance, reimburses providers for specific care that they provide, treatments that they give, visits that they make, prescriptions that they fill. But in addition, it also makes these discretionary supplemental payments. And the idea is that Medicaid pays low rates. And so that puts a burden on the providers that treat a disproportionate share of Medicaid recipients. And the supplemental funding is supposed to make up for that. You could ask, why don't they just raise the rates instead of providing these supplemental grants? I think as a practical matter, it's because the state likes the discretion and the flexibility that it gets. It can target money where it thinks it's most needed, and sometimes it does. It goes into that process with the right intentions, but it ends up getting distorted by politics, and so that part of the system is both getting more expensive and it's not always very functional. Starting with, I believe, with Mario Cuomo, the state has outsourced a lot of Medicaid, where instead of directly reimbursing providers, it buys coverage from managed care plans. It pays a monthly premium. The managed care plans become responsible for processing claims and they take on the risk when there's a high cost procedure. And they also do what, old fashioned management to some extent, where they kind of look at the big picture of what services a given patient is getting from various providers who aren't necessarily speaking to each other. And so the managed care plan can coordinate that and even nudge people to get tests and preventive procedures that they may have neglected. The global cap is something that Cuomo put in early in his term. The idea was to set a kind of benchmark for how much the state wanted to let Medicaid grow and then try to live under that cap. It was never really global. It only applied to the state share, and then it only applied to a portion of the state share. Over the years, more and more Medicaid spending has been going on outside of the cap. And also Governor Hochul changed the cap. So she chose the new benchmark. It used to be medical inflation, and now it's based on a projected rate of growth in total Medicaid spending at the national level. It's a much higher rate of growth, and that's sort of allowed the spending to grow at a faster rate. The pandemic, as it did with so many things, it also disrupted Medicaid. On the one hand, you had a drop in demand for overall medical care because people were afraid to go to their doctor or go to the hospital. And also elective procedures were suspended. So that helped reduce costs temporarily. The federal government also came in with a bunch of extra aid as like a pandemic relief measure. So that reduced the state's share of costs. On the other hand, during the pandemic emergency, the federal government also barred states from restricting eligibility and restricting coverage. It just so happened that New York State had gone through a round of cost-cutting reforms in early 2020, just before the pandemic, and most of those or a lot of them had to be put on hold while the emergency continued, which it only ended in the spring of 2023. In addition, the federal government said that states should not be pruning people off of their rolls. So once you were signed up for Medicaid during the pandemic emergency, you stayed on Medicaid regardless of whether your income increased or you got a job or you even acquired insurance. And that caused the Medicaid rolls to be inflated. And only now are we beginning to reduce that. So here are some of the basic numbers about New York's Medicaid program. As of November, it was covering 7.6 million people, or about 39% of the state's population. I think that's a sign that, and in New York City, it's even a higher share. It's just over half I think that's a sign that it's not really a safety net program in the usual sense. It's become more of a catch-all um, insurance option for people who don't have other coverage, and it's just obviously a huge part of our overall healthcare system. In terms of the share of population enrolled, New York is third among the 50 states. In terms of spending per enrollee, per Medicaid recipient, we're fifth. Only 4 states spend more than we do. And because of those two things together, broad enrollment and high spending per enrollee, we get to a statistic which I think should be kept in mind as the budget debate unfolds, and that is that we spend more per capita, more per resident than any state, and we're 70% above the U.S. average. So by almost any standard, New York has a very generously funded Medicaid program. It's not to say it's perfect, but New York spends just unquestionably a lot of money on Medicaid. This is what's happened to enrollment over the last decade or so. We've had 2 big surges. One, when the Affordable Care Act took effect in 2014, we added about 1 million people over the next 2 years. It leveled off after that at about 6 million. And then when the pandemic hit, we had an even larger surge in enrollment where it went up 2 million people. Again, that's a mix of people who suddenly lost their jobs and their health insurance and fell into the safety net, but also people who stayed on Medicaid, who no longer needed it, but stayed on Medicaid because of that federal requirement, which was known as continuous coverage. And then you can see the very right-hand side of the chart, there's a pretty sharp decline there, and that is the unwinding process. That's the state pruning people off the rolls based on the fact that they are no longer eligible. So there's a central fact about Medicaid that has really changed dramatically in recent years. This is kind of the core population who the Medicaid is meant to serve. It's non-elderly people under 138% of the federal poverty level. And you can see it's generally been declining until the pandemic when it bumped up again. But it's still lower than it was 10 years ago. And this is what's happened to enrollment during that time. Enrollment has gotten increasingly disconnected from poverty, and to the point in 2019 where more than half of the enrollment was people above the poverty line. And I'm not exactly sure how that happened. It's happening in other states, but it's the gap between poverty and enrollment in New York is the widest, or among the widest of any state. And regardless of how it's happening, I think it is changing the nature of Medicaid. It's becoming less of a safety net program and more of a mainstream catch-all. And I think there's a downside to that, among others, where it's taking the focus away from the people who need it most, the truly disabled and the truly indigent, and it's putting more and more money, resources, and attention are being given to this less needy group. I should pause now and say that I'm covering a lot of material in a hurry. I'm hoping you will have questions for me at the end, and please put those in the Q&A. This is what's going on with spending. From the last year before the pandemic, in terms of state fiscal years, was 2020. We were spending 75 billion at that point, and now we're almost to 100 billion. Just over half of that money is coming from the federal government. About 36% is coming from the state, and the last 8.5% is coming from the local governments. I think you can see it was kind of flat during the early years of Governor Cuomo's term, and then it started increasing later in his term. But since the pandemic and since Governor Hochul took over, it has really kicked into a new gear. This is zeroing in just on the state share, the blue part of the previous chart. you can see it's a little hard to see the growth rate of that. And this is pulling that out. In percentage terms, since 2011, you had kind of slow but steady growth through 2019. You had a kind of spike in 2020, just before the pandemic. It dipped during the pandemic dramatically, an almost unprecedented dip. But since then, it has not only bounced back from the pandemic, but it has really taken off at a new level. So we had a 20-something% increase in 2022, which was Governor Cuomo's last budget. And then we've had a 13% increase followed by a 15% increase in the next 2 years. So you just it's a very a pace of growth like none that I think I've ever seen, and maybe unprecedented in the history of the program. And one side effect is that it is now surpassing school aid by a convincing margin as the most expensive thing in the state budget. Those two things kind of jockeyed back and forth. The dark blue line and the red line are, red is Medicaid and the dark blue is school aid. Just in the past few years, you can see the growth. School aid has been growing rapidly too. I think we've, correctly, there's been a lot of discussion about how we're making unprecedented investments in school aid, but Medicaid has grown even faster than that. And it's on track. The gray line is kind of base school aid plus star tax relief and special ed, and Medicaid is also on track, if current trends hold, to pretty significantly surpass that as well. This is zeroing in on the governor's budget proposal. So this is just state operations Medicaid spending. You can see the dip during the pandemic and then the sharp rise after that. The governor is now sort of very openly hitting the brakes. She's become concerned about the rate of growth and whether it's sustainable. And so she's actually calling for a small increase in total state share Medicaid spending in 2025, according to her projections. But you can see that even the 2025 amount, although it's slightly smaller than 24, is still a lot bigger than 23 or 22 or 21.
For more news and analysis, visit our website and sign up for email updates at empirecenter.org. Follow us on Twitter, Facebook, and LinkedIn at Empire Center.
Is upward. I have lost my controls. Okay, here we go. Why is this growth happening? We saw before that it's not because of a big increase in poverty. So let's talk about why it is happening. One big factor is the higher minimum wage. Minimum wage was $9 in 2016, and it's heading towards 20 and beyond right now. And in addition, there are extra minimum wages for certain classes of healthcare workers, especially home health aides. And the state recognizes that that's a burden on providers. It is specifically reimbursing them for those costs. And that reimbursement, just for the delta in the minimum wage, is now in the neighborhood of $5 or $6 billion, half of which comes from the state. At the same time, the demand for and the utilization of home care has been spiraling. We'll go into more detail about that in a couple of slides. We've also been putting more money into subsidies for distressed providers. And this once you've given a provider funding to keep it open, it becomes difficult to pull that back, because there's a chance, especially if it's a hospital, there's a chance they would have to close or it wouldn't meet payroll. And that's politically difficult. And so what we're doing is we're kind of subsidizing hospitals that have structural problems that they haven't addressed, that they've lost demand for their product. Their patients have either need less care or they've gone elsewhere. And so that, coupled with the fact that Medicaid is not paying them, standard fees, causes them to lose money, and the state is paying 25, 30, 35% of their operating costs in some cases, just as a straight subsidy. The emergency rules, to some extent, contributed to the cost, as I mentioned before, because the state was unable to implement some cost controls, but also because enrollment was inflated. So that was another factor. Governor Hochul, one of her priorities in her first budget was to pay bonuses to healthcare workers. That was $2.6 billion investment. She initially thought that the federal government would match that, so it would only be half state, half federal. The federal government has decided not to match it, so now the full $2.6 billion has to come out of the state funds. And then the state also agreed to some substantial rate increases. The industry will tell you that the rates were essentially frozen for about a decade before that. That's not exactly the case. There were small increases, and there are other things that are outside the base rate that increased their funding to some extent. They certainly weren't completely frozen, but the rates probably were overdue for an adjustment, and the level of increases that they've gotten in the last couple of years is the highest I've ever seen. They add hundreds of millions, if not billions, to the overall budget, and they also have not quieted down the demand for more rate increases. We're seeing a lot of lobbying this year for more. The global cap that the governor Cuomo first imposed in the early 2012, I think it was, that has gotten weaker, and that is essentially allowed spending to grow at a faster rate. So going back to what I said about home care, the subcategory of home care is called personal care, and that's kind of the non-medical services that disabled people are entitled to receive in their homes. And that can be just help with getting in and out of bed, bathing, feeding, house cleaning, shopping. If somebody's disabled, they can't do that for themselves, and they otherwise meet the qualifications for the program. We've just seen an extreme level of growth in this program. I think a lot of people assume it has to do with our aging population, but I'm here to tell you the growth of this program is about 5 times faster than the growth of our aging population. And we're also off the charts compared to other states. In 2016, we accounted for about 40% of national Medicaid spending on personal care. So we have 6% of the population, and we were spending 40% of the money. I think by now, given what's happened since 2016, we're almost certainly spending more on personal care than the other 49 states combined. And I think part of what happened is many of you may have seen advertisements saying, get paid for taking care of your family members. And that's a reference to the Consumer-Directed Personal Assistance Program, which is a wonderful program in many ways. But it's also a very tempting program for a lot of people. And you had a burst of companies created called fiscal intermediaries who participate in this program, and they are out there trying to drum up enrollment, and it's working. They're finding people who are interested in the program, and they're finding families who want it, and they're helping them qualify, and the state is just spending an enormous amount of money on home care. This is another way of looking at our per capita expenditures on personal assistance are 7 times higher than the national average, and a complete outlier compared to other states. In fact, there are, I think, 17 states that don't offer the benefit at all. So this is, compared to the 33 states that do offer it, we are off the charts. This is a quick look at the global cap and how it's gotten weaker. The blue bar is the amount of spending that's under the cap, and the gray bar is the total amount of spending. And you can see that the blue bar has grown at a faster rate in recent years, but also that the total spending has gotten increasingly disconnected from the amount controlled by the cap. So a couple of the hot topics this year, and I'll try to keep this short because I want to take questions. There's talk about closing the Medicaid gap. I think it's being described as being a 30% gap. I'm not clear where that percentage comes from, but again, we are a very high spending Medicaid state. We're also our hospitals are well funded compared to other states from all sources, not just including Medicaid. The proposal on the table would be enormously expensive. I don't think it would prove to be sustainable, especially if you took it beyond hospitals and you tried to close the gap, or you tried to do a 30% increase for all providers. It would be $43 billion or something like that. That's part of a general trend of asking for rate increases. It is true that Medicaid pays less than commercial insurance, but in general, it's on par with Medicare. And in fact, the federal government doesn't want states to reimburse providers more than the Medicare rate. And so we may be running up against that limit in some areas. There's some discussion about the future of managed care. The governor is saying she wants to do competitive bidding. Some people in the legislature want to eliminate it completely in the long-term care space. I think in terms of eliminating it, I think the state should be aware that the savings estimates are grossly inflated. In fact, there's a school of thought that it would actually add to cost to eliminate it. But also you want to think carefully about whether you want to lose the management function, which the state is dependent on to track the delivery of services, to monitor it, to in some cases to limit it. And another thing to watch is the unwinding process. It's moving more slowly than the state projected. There's a lot of concern about not disenrolling people for the wrong reasons, to make sure you're disenrolling them for the right reasons. The controller flagged the fact that this was going more slowly, and that means that we're going to have extra enrollment next year, which may be an added expense. Actually, the people who are in line to be disenrolled are not an expensive population. They're mostly healthy, able-bodied. A lot of them have jobs. A lot of them, in fact, have alternate insurance. So they're not really using their Medicaid benefit much, if at all. And so it is something to watch. It is a concern, but it's not, this is not the really expensive Medicaid population. And another kind of surprising development, the governor is talking about taking away, there's certain wage supplements that are paid to home health aides in the New York City area and the surrounding suburbs. And she's talking about taking them away, but only from the consumer-directed part of the personal care system. And I have to say, I think that may be politically driven, because that part of the system, it is fast growing, but it's also non-unionized. And so I don't know why it would make sense to take away those wage supplements for that part of the system and not touch the agency-based home care, which is more unionized. And also, I don't think those wage supplements, they are a contributor to costs, but they're not the fundamental reason why costs are rising so fast. The reason why costs are rising so fast has to do with how many people are being found to be eligible and the level of services that they're getting. So I'd be very happy in the time we have left to take questions. And in fact, if people want to hang around beyond the scheduled end of this webinar, I'd be happy to continue taking questions. So Kyle is going to take care of asking the questions.
So we did have several questions come in, Bill, so I'm going to go through some of them. One question, what explains the number of people not in poverty who are on Medicaid?
This is a bit of a mystery to me. I mean, there are situations where you can be above the poverty level and qualify for Medicaid. So if you're having a particular health crisis that you can't afford to pay for, you can buy into Medicaid, or you can split the costs with Medicaid in some cases. Another factor might be that the census measures income a little bit differently than the Medicaid system does. But I do think it bears investigating, because it's just surprising to me that, given the structural rules that are in place that are supposed to limit Medicaid to low-income people, to see 51% of the population of New York City or 39% of the population statewide qualifying, it's puzzling to me. It's happening in other states, so it's not unique to New York, but it's happening a lot in New York. There are situations also where you can be eligible for both Medicare and Medicaid. So there's several 100,000 people in that category as well.
We also had a couple questions come in about being willing to share your slides and if this video will be made available, and we can make both those available.
Yeah, and also I will say I'm if people want to contact me by email or phone afterwards, I'm always happy to talk about this stuff.
All right. What category of spending within the total Medicaid spend has increased the most and the fastest?
Oh, that's going to be the home care, and particularly the personal care. This is one of those things where, there's 7.5 million people in the program, but there's probably 20% of those people that account for 80% of the cost. And personal care can be very expensive. It's usually considered to be less expensive than a nursing home, but there are some people who are getting home care around the clock, 24/7, and that requires, 2 or 3 or more aides to be working with that person full time, and that can add up to, hundreds of thousands of dollars. So there are other people who are just getting, 4 to 8 hours a week, and that's relatively inexpensive.
So we have an interesting question. Do you have any data on the economic impact of investing in our population's health? It seems that focusing on this data in a silo is not a true picture of the cost benefit. So I think they might be driving at, like, do we have any way to measure the population's health?
We are generally a healthy state. I mean, I sometimes look at that. We don't have especially high rates of diabetes or obesity, or we're a little bit older than average, not dramatically so. It's not. I guess you could argue that our high spending on healthcare is part of the reason for that. I think it has more to do with demographics. I think, but it's true. This is a huge part of our economy. It's a huge part of the nation's economy, and it's a huge part of our economy. There probably are some economic. I mean, certainly, if you're employed in this industry, you're making good money, and these are generally good jobs that come with benefits and stuff like that. The thing is, there's also a lot of discussion these days about the cost of living in New York, and this is part of the cost of living, because that money that the healthcare system is making comes out of our taxes, and it comes out of our health premiums. And so our health premiums are high compared to the rest of the country, and our taxes are high compared to the rest of the country. So it has both positive and negative effects for the economy.
Can you comment on the profit margins for fiscal intermediaries for consumer-driven patient assistance program?
I'd be interested to know that. I think the state is in the process of getting them to report their finances. Until not too long ago, they were completely exempt from any kind of financial reporting. So it would be interesting to know what their profit level is. They are in traditional home care. There's an agency that's the employer of the home care aide, and the agency does, manages the employees, and it works with the clients to manage their needs. And the agency is the employer, and so they do the payroll and pull out the taxes and stuff. In consumer directed, there is no agency. The home health aide works directly with the client. So you need the fiscal intermediary's role is just to be mainly to be a payroll processing firm. And yet the way the reimbursement works is they get a share of the hourly rate. So the more hours that the more hours that a given patient receives in home care, the more money the fiscal intermediary makes. And so I think that bears some scrutiny. there may be some quite high profit rates in that industry.
That question goes on and notes, and forgive me, you might know the acronym, Bill, but it says that MLTCs are paid a flat amount while the fiscal intermediaries are paid by the hour. Does that make sense to you?
MLTC is a reference to managed long-term care plans. These are insurance plans that contract with the state. They receive a monthly premium for each enrollee, and then they are in charge of reimbursing the care. And most of what they reimburse for is home care and personal care. So they're dealing both with home care agencies and with fiscal intermediaries. And it's true, the MLTC is getting a flat monthly amount per enrollee, and the fiscal intermediary is paid by the hour.
So how much of a cost driver are Medicaid paying nursing home placements? And is there a way for the state to look into preventative measures to keep people in a different setting?
This is something, another puzzle to me. We, as I tried to demonstrate, we spend an extraordinary amount on home care. And part of the logic of spending that much on home care is to keep people out of nursing homes. And it's definitely, I think, generally regarded that it's a preferable option to not go to a nursing home if you can avoid it. But New York has a high nursing home population compared to other states. So evidently, despite our extraordinary spending, we're not keeping people out of nursing homes. I mean, I'm assuming that some of the people who get home care now would be in a nursing home, and there are also people in nursing homes who probably would qualify for home care. And somehow we're spending $12 billion a year, but we're not targeting it to the people who need it the most. And it's not resulting in a smaller nursing home population than, and actually we have a higher nursing home population relative to our size than most other states.
Are there proposals to cut back on home health care?
There are, and I have to say I'm not absolutely up to speed on exactly where they stand, but the one big proposal that was passed in 2020, which I believe is in the process of being implemented, was to tighten the medical eligibility. So to say you need to have, there's this phenomenon called activities of daily living. So if you can't feed yourself, or if you can't get in and out of bed, or if you can't bathe yourself, each of those is an activity of daily living. And if you need help with at least two of those, I think was the rule, you qualify for home care. And so the proposal in 2020 was to tighten that a little bit, to say how many activities of daily living you need to be limited on, and there was a kind of another clause if you were suffering from dementia. So that was kind of the proposal on the table. There's also there's some thought that doing a competitive bidding process for the managed long-term care plans would save money, because you have a certain number of these managed long-term care plans that are pretty small, and there's some thinking that if you consolidate into larger plans, you would save money that way. I have to say I don't see anything on the table that's going to, turn this around and like even necessarily stop the growth, let alone reverse it.
So we do have several more questions. I do want to be respectful of everyone's time. So if you have to jump, I completely understand that. But we're going to keep rolling and keep going through Q&A, because there's a lot of really good questions here, Bill, and I want to make sure that they get answered for everyone. So
I'm happy to do it.
Home care seems to be the biggest problem. What reforms would you suggest to bring home care under control?
It's a tough one. I actually think this is a situation where we need more information to really understand why it's happening and then tackle that. I think there's been a kind of cultural shift. I think a lot of what home care is doing is what people would have done for their own family members without reimbursement in the past. In some cases, the families asking families to take care of their loved ones without reimbursement is a big burden. There are obviously situations where, say, somebody's mother needs a lot of attention, and so somebody has to stop working in order to provide that attention, and so that's an economic loss for that family. On the other hand, I think I don't know that it's the state's role to take care of everybody's family, and especially if those families have resources of their own. And so that's one issue. It's kind of a cultural issue. Another issue is, to what extent are we being outright defrauded? Every now and then there will be a case where, because home care goes on in a private setting and there's no manager on site, there's no guarantee that the worker is going to appear when they're supposed to appear. And every now and then you'll see a case where the recipient of the care and the caregiver are working together. The patient agrees that the caregiver will not actually work, but they will split the paycheck. And sometimes the other parts of the system are in on that deal. So every now and then you see a prosecution for that. And I think it's a very high risk situation for fraud, and I think we should take that risk seriously and do more policing of it.
Bill, I don't know if you'll have an answer to this because you're not in the room during the negotiation process, but what would you say is the biggest sticking point in the budget negotiations regarding Medicaid?
I'm waiting to find out. It didn't feel to me like the governor had a big ask in this area, other than she wants spending restraint. And obviously there are elements in the legislature that are going in exactly the opposite direction. They want a big increase in spending. And so I think that's ultimately, where that comes out is probably the sticking point, at least in terms of Medicaid.
Do you have a sense of the share of the home care population that are dual Medicaid, Medicare covered?
I think it's going to be most of them. This is an issue with this Medicaid system generally, that we don't have a lot of data about how the money's spent. The state traditionally in its financial plan has laid out where the money comes from. And there's some reporting about different categories of enrollment, but it's not easy to get your hands on how much are we spending on nursing homes versus home care. And also it's not easy to get your hands on how much are we spending on the elderly versus, people under 65. My guess would be that most of it is people on Medicare, either because they're elderly or because they're disabled.
What portion of home health care cost is attributed to unionized employees?
I don't know the answer to that. I know, as I said before, the unions are mostly active. They're not active at all in the consumer-directed programs, which is close to half, I think, of all home care. The agency-based is where the unions are most active, but I couldn't tell you what their penetration is in that space.
I
know that there are hundreds of thousands of home care aides who are unionized, and I say hundreds of thousands. I'm not actually sure. There are about 500,000 total home health aides in the state, and certainly 1199 represents tens of thousands of them. I don't know if they represent hundreds.
Another question. I think there's 3 more in the chat, so we'll go through 3 more questions and then we'll close things out. But do illegal migrants receive Medicaid in New York? Is there a proposal to cover them, notwithstanding already out of control costs?
It's kind of a complicated. There's this thing called emergency Medicaid, which is if someone shows up in the emergency room, regardless of their citizenship status, and they need acute care and they don't have the ability to pay, Medicaid pays for some of that. But it's kind of limited to emergency situations. Actually, what New York has a court ruling called the Aliesa case, which says New York has to provide Medicaid coverage even to immigrants who are not eligible for federal matching funds. For a long time, it did that through the Medicaid system. So it was paying 100% of the cost for those enrollees. And by the way, not all immigrants are covered by that court ruling. It's the shorthand for that is people residing under color of law, call. And that's people who are kind of in an ambiguous status where they are here, but they don't have all their paperwork lined up. It gets very complicated drawing the lines in that. But so a portion of immigrants are eligible for state-funded healthcare under a court ruling. Most of those people are now in the essential plan, though, which is like Medicaid, but it's separate and different for technical reasons. So a large share, it's hundreds of thousands of undocumented immigrants are getting state-funded healthcare through the essential plan, by and large. Some of them are getting emergency Medicaid, but then there's another, probably in the hundreds of thousands of people who don't have coverage at all. I guess another option in New York City is this thing called New York City Cares, which is operated by the City Health and Hospitals Corporation, which is open to people who live in New York City regardless of their immigration status. It's not exactly insurance, but it's kind of it's meant to be a health. You sign up for it, you get a card, and you can use the city's various health providers under that program.
So this one's more of a comment, but I'll see if you have any thoughts about it, Bill. Overall nursing home spend statewide has been declining. There's also been 32 nursing home closures in 15 years. Upstate nursing homes have a higher vacancy rate than ever before and are not recovering from the pandemic. Any thoughts on that?
I mean, I have to say that is the one part of the healthcare industry that even I would agree is in crisis. I think there's a lot of talk about crisis because that's a way of lobbying for more money in Albany to portray yourself as being in crisis. The nursing home industry really is. It's part of the reason that the spend has declined is because the number of residents has declined. I mean, tragically, we lost a bunch of residents during the pandemic because they died. But also people stopped checking into nursing homes. They worked even harder to stay away from nursing homes because of what happened during the pandemic. So the demand for nursing home care is down considerably. So in addition to facilities closing, a lot of them have been converting. So either they used to be county operated and now they're private. They used to be not-for-profit and now they're for-profit. There's a lot of turmoil in the nursing home industry. And on top of all that, there are these lawsuits by the Attorney General that are exposing what she believes to be a combination of neglect, abuse, and fraud, because the companies she's suing, according to her, are siphoning money out of these facilities while they neglect the patients. And the defendants in those cases, she's targeted, I think, a half dozen individual facilities, but the defendants in those cases are the owners of those facilities own dozens of other nursing homes around the state. So those other nursing homes are not involved in the lawsuit, but the owners are. And it's quite an indictment of how the industry is operating. And I've been waiting to see a response from the health department and from the legislature where they will bring the Attorney General in and ask her people, what are they seeing in the industry and what should they be doing differently?
All right, last question, Bill, and I think you've already kind of touched on it. The questioner asks, this is obviously going to bankrupt the state. Is there any move afoot in Albany to cut the program?
I mean, whether it bankrupts the state, the state has been finding the money to pay for Medicaid. It's been giving, Medicaid is more and more of the state's total budget. Medicaid and education combined are more than half of the state budget, and that percentage has been growing. But it does, like, it constantly is straining finances. It's like this year it ran $1.5 billion over budget. And that money, Governor Hochul found the money somewhere, but it came out of some other program, or it came out of reserves. And I mean, that's kind of her message, is that we can't sustain the level of growth that we've seen in this program. But her budget includes what she calls unallocated cuts. So, several $100 million where she's not specifying what she's going to do to save that money. The implication is she wants to negotiate that with the legislature, but the legislature isn't interested in cutting Medicaid. They're not, they'd rather see it increase. And if necessary, they'd rather raise taxes to pay for it. So there's kind of a, there's not a meeting of minds there. And it is definitely straining the state's finances. And that's kind of maybe one of the bigger questions of this session, is how the governor and the legislature meet. They have some wiggle room, I have to say. They, because the state has reserves, and because revenues right now are coming in at a relatively healthy rate, they may find a way to finesse it. But longer term, the level of growth that we're seeing, I would agree, is just not sustainable.
Well, Bill, I want to thank you for taking the time to dive into this really complex topic. Thank you, everyone, for joining this webinar, this Think New York webinar. Stay tuned next month, because we will have another Think New York webinar. But until then, we will see you all soon.